We're here to talk about inflammatory breast cancer. My name's Ginny Mason. I'm with the Inflammatory Breast Cancer Research Foundation, and I'm going to be talking with my friend and former physician, Dr. George Sledge, who is a professor of medicine at Stanford University. Welcome, George.
Hey, Jenny. So good to see you again.
Nice to see you as well. Sorry that we can't be in the same spot.
Indeed.
Well, I wanted to talk to you today about inflammatory breast cancer. You serve on our medical advisory board for our organization, and we've known one another for, I figure, about 20 years, give or take a year.
My hair was darker then.
So was mine. But I know when I first got to see you, I had just finished my active treatment, and you took me on as hopefully a stable patient. But I learned a lot of things over the course of these 20 years about inflammatory breast cancer that I didn't know when I was diagnosed. Mm-hmm. And part of what we want to do today is help other advocates and potential patients understand the whole process from symptoms and diagnosis through treatment, perhaps reconstruction, and talk a little bit about what the research is in the area. So first, to talk about just what is inflammatory breast cancer. I know people assume there is just one kind of breast cancer. As we know, there are many different kinds, many subtypes. 20 years ago, I'm not sure we were as familiar with that piece. But how would you describe inflammatory breast cancer?
Well, let's start with the name. We call it inflammatory breast cancer because when you observe the breast of a woman with inflammatory breast cancer, it looks inflamed. And the classic diagnosis of inflammatory breast cancer is a clinical diagnosis. It has pathologic diagnostic elements to it, but we start by looking at the clinical diagnostic characteristics. If you look at the breast of a woman who has inflammatory breast cancer, the breast is inflamed. It's reddish or reddish purplish in some cases. The skin itself tends to be thicker than the skin of a normal breast. It may involve the entire breast or may involve just a part of the breast. The breast, in addition, if one looks at the skin has what doctors call peau d'orange. Peau d'orange, by the way, is French, basically French for orange peel. And if you think of an orange and think of that sort of pitting or dimpling that one sees in an orange, that's frequently what you see in inflammatory breast cancer as well, where as a result of more fluid being trapped in the skin is edematous, has a somewhat boggy feel and look to it. You get that pitting look that one can see if one looks closely. So all this together is something that old breast cancer hands are used to seeing. This is a rarer rather than a more common diagnosis. It occurs somewhere in the range of 2 to 5% of all breast cancer patients that we see. Once we see it, then the question is, first, since we always require a pathologic diagnosis before we tell someone they have breast cancer, what do we actually biopsy? Because when we work up someone for inflammatory breast cancer diagnostically, if for instance you get a mammogram on a patient, you may not see anything on the mammogram. Even on a breast MRI, sometimes you may not see a distinct mass. But when we talk about inflammatory breast cancer, what we're talking about is a breast cancer that started in the breast and now involves the skin over the breast. So one thing that we usually do, if we suspect inflammatory breast cancer, is to get a skin biopsy. And in the skin biopsy, if we're fortunate enough to biopsy the area where the cancer is, and we're not always that fortunate, but if we're fortunate enough to biopsy the area where the cancer is, what we then see is what pathologists call invasion of the dermal lymphatics with breast cancer cells. The lymph vessels in the skin are basically plugged up with cancer cells. And this plugging of the lymph channels in the skin is what leads to that sort of boggy, distended feeling that one feels in the skin of the breast and the pitting one sees and the erythema or inflammation that one sees in association with inflammatory breast cancer.
So it's hard to pick up on standard imaging unless you've got someone who really knows what they're looking for.
It can be difficult. Yes, it can be
Mhm.
difficult. And it's not always straightforward. We certainly don't always see the clustered microcalcifications or distinct mass that we see in more common breast cancer.
Does MRI or ultrasound do a better job of picking up potential inflammatory breast cancer?
In my experience, and I think in the literature, MRI is certainly a bit better at picking things up than a screening mammography. But it varies, and it can be difficult even in the best of hands. And again, this is why I emphasize this is basically a clinical diagnosis.
Right. Sadly, we still don't have a diagnostic code for inflammatory breast cancer. And so it makes it much harder to know just how much of us are out here, how many patients there are.
Indeed.
You have to look at a narrative in somebody's chart to find out if it was even mentioned.
I think it's a really good point. And again, its relative rarity, I think, has led to it being perhaps undiagnosed, certainly misunderstood, and certainly not as well studied as we would like. We do know some things about the epidemiology of inflammatory breast cancer. The women who have inflammatory breast cancer skew a little bit younger than the general population of breast cancer patients. African American women are somewhat more likely to have inflammatory breast cancer. So there's some real health disparity issues. The breast cancers themselves tend to skew a little bit differently than the more general population of breast cancers in terms of the type of breast cancers that we see. So it's clearly marks itself out as a somewhat different entity than what we normally see in breast cancer.
And my understanding is about a third of patients diagnosed are already at a stage 4 as opposed to stage 3, which IBC is always at a stage 3 or higher at diagnosis.
That's correct. And so certainly if we see a woman who appears to have inflammatory breast cancer, and indeed if we get a biopsy and see that invasion of the dermal lymphatics, one of the very first things that we do is a scan for the entire body. That could be either a CT scan of the chest, abdomen, and pelvis, along with a bone scan, or it could be a PET CT scan. But because of that high frequency of distant disease at the time of diagnosis, we always go looking for it.
Yeah, it's frustrating, I think, to note that 20 years ago, or more than 20 now for me, it was very difficult to get anyone to pay attention to my symptoms because I was 40 years old and I had no family history of breast cancer. And so when I was finally diagnosed, I was very fortunate that mine was just at a 3B or C. Now it would be considered C. Mm-hmm. But sadly, we still see that today. It just seems like more and more people still have difficulty getting anyone to take their symptoms seriously, especially if they're very young.
Well, and we see it in part because of misdiagnosis, and that's to say, it's frequently misdiagnosed as a bacterial mastitis, basically as a skin infection of the breast. And so I'll frequently see patients with inflammatory disease who might have received several rounds of antibiotics before someone actually stopped to think that perhaps this is something other than an infection.
Yes, it's been helpful that the National Comprehensive Cancer Network have added more specific guidelines in their screening guidelines to guide physicians in looking for inflammatory breast cancer, as well as treatment guidelines, so that those who are in a more community setting and may not have as much specific breast experience have some guidance on that.
Indeed, and if you're an internist or a family practitioner or a gynecologist, who of course collectively see the vast majority of younger women, not medical oncologists or surgical oncologists, they may go an entire career without seeing more than one or two of these. So having it in the forefront of your mind is like all things difficult if you just haven't had much experience with it. Right.
I was very fortunate that my general surgeon had seen a case before when I finally did make it to a surgeon.
Indeed. Makes a difference.
It does. Well, how about treatment? Since I mentioned the NCCN treatment guidelines, I remember when I was diagnosed, giving chemotherapy first was a very new idea. That was 1994, and it was still standard to just do surgery first for any breast cancer.
Mhm.
But my doctors contacted the National Cancer Institute, and their tumor board suggested trying neoadjuvant chemotherapy.
Mhm.
I was willing to do whatever was necessary, so I said, sure, let's try that. But that's been a big change, hasn't it?
Yeah, and it changed right around the time that you're mentioning. I had the good fortune to be trained in a program that was strong in breast cancer, so we were doing that fairly early on during my fellowship. But in a lot of places, it took a long time to realize that. Now, part of this comes from just simply the old literature of inflammatory breast cancer, which dates from a time prior to modern chemotherapy regimens. And if you look at patients who had inflammatory breast cancer and had surgery or surgery and radiation therapy, there was an exceptionally high risk of local recurrence prior to the chemotherapy era. So when chemotherapy came along and we started using preoperative or so-called neoadjuvant chemotherapy, that allowed us to significantly shrink these tumors before a patient would go to surgery or surgery and radiation therapy. And that more or less immediately markedly reduced the risk of having a local recurrence of breast cancer from something that was exceptionally common to something that, while not unheard of, was certainly much, much rarer. And so that's been the standard of care now for the last quarter of a century or so for patients to receive preoperative systemic therapy. Now, when I say systemic therapy, in the era that you were in, Ginny, in terms of your diagnosis, systemic therapy routinely meant chemotherapy and chemotherapy alone.
Right.
But the other thing that we know about inflammatory breast cancer, and this is really, really important as it turns out, is that inflammatory breast cancer can be one of several types of breast cancer. Now, when I sit down and talk to my fellows in the clinic and try to explain breast cancer to them, my homely metaphor is to say that imagine a boarding house where a bunch of criminals hang out together, and some of them are petty thieves and some of them are murderers, and you have to apprehend them differently, and they have to be punished differently. And that's absolutely the case for not just for breast cancer in general, but for inflammatory breast cancer in particular. Mm-hmm. We see all three of the major subtypes of breast cancer represented among inflammatory breast cancer patients who have estrogen receptor positive tumors, though this is quite a bit rarer than what we see in the general population of breast cancer patients, HER2 positive tumors, and then so-called triple negative breast cancers that lack both estrogen receptor, progesterone receptor, and HER2. And indeed, the majority of patients with inflammatory breast cancer are either going to have a triple negative breast cancer or HER2 positive breast cancer. Knowing that early on is crucial in terms of looking at what sort of therapy one might use, and indeed crucial in terms of maximizing a patient's long-term prognosis. So, for instance, if a patient has a triple negative breast cancer, until very recently, one would have said that we were doing the same thing we were doing back in the early 1990s, and that's to say that we'd be using some form of chemotherapy. And that would typically be a chemotherapy that would involve anthracyclines, such as adriamycin, and taxanes, such as Taxol or Taxotere. Very, very recently, the world of triple negative breast cancer, particularly early stage triple negative breast cancer, has changed dramatically as a result of the addition of what are called checkpoint inhibitors to our therapeutic armamentarium. These are basically drugs that goose the body's immune system to attack the breast cancer. And recent data, and indeed a large phase 3 trial that included patients with locally advanced breast cancer, has shown that if one adds a checkpoint inhibitor to chemotherapy, that significantly increases the rate of having what we call pathologic complete remission, that's to say no tumor found when you go to surgery, and has significantly reduced the likelihood of having a distant recurrence. Now, the studies that demonstrated this were primarily studies that were not done in inflammatory breast cancer patients. We actually have shockingly little data in inflammatory breast cancers. Right. But for all the reasons we've discussed in the past. But I think it's eminently reasonable to say if this works for other locally advanced breast cancers, it's very reasonable for a triple negative breast cancer that's inflammatory to include a checkpoint inhibitor.
I'm seeing that in some of the newer diagnosed individuals that I encounter on both social media groups and in private conversations. We get a lot of individuals contacting our organization with questions about treatment. And one of the reasons I try to stay as current as I can on what's happening in the broader breast cancer field, because much of it is translated over into being used in inflammatory breast cancer as well.
Indeed.
And you brought up an important point that, we often have difficulty determining just what's the best treatment for inflammatory breast cancer because it's hard to do trials. You don't find a population of inflammatory breast cancer patients very neatly collected in one geographic area.
No, and even above and beyond that issue, which is a real one, which means that there's only literally a small handful of centers in the United States that have devoted inflammatory breast cancer clinics.
Right.
Even above and beyond that problem, many of the trials in which we give preoperative therapy that have involved the production and generation of new drug indications by the FDA in recent years have specifically excluded patients with inflammatory breast cancer from the trials,
Right.
which I think you and I probably both think is a shame and a missed opportunity.
One of the reasons I've gotten so actively involved in clinical trial development.
Yeah, indeed. Now, having said that, to my mind, it would be a crying shame if we had to wait a decade for a phase 3 trial result before we included things that we know save lives
Right.
in other locally advanced breast cancer in the inflammatory situation. Moving on to HER2 positive breast cancer.
Mm-hmm.
We have compelling evidence that if you add HER2 targeted therapy to chemotherapy, that increases the likelihood of having what we call a pathologic complete response in patients with locally advanced breast cancers. That field continues to evolve. The standard approach these days involves a combination of chemotherapy with dual antibody therapy with trastuzumab and pertuzumab. And certainly if I had a HER2 positive breast cancer patient who had inflammatory breast cancer, I would certainly start with that sort of approach. We also know that if those patients have residual disease in their breast or their lymph nodes when they go to surgery, can benefit from further HER2 targeted therapy, the drug called TDM1, which is another HER2 targeted agent. Certainly that approach is, again, a very reasonable one for patients with inflammatory breast cancer. My guess is that field is going to continue to evolve fairly rapidly as well, because we have a bunch of new HER2 targeted agents coming along. Drugs that involve what are called antibody drug conjugates, drugs where basically we take a HER2 targeting antibody and add a poison to it and let the antibody take the poison to the cancer cell. But we also have new oral medications, new what are called kinase inhibitors that specifically target HER2 that look to be very effective and active for patients with advanced disease. And all of these are moving quickly into earlier disease settings, and therefore I think will be available to patients with inflammatory breast cancer in the very near future.
Yeah, time was when you heard HER2 positivity linked to your cancer that you were terrified that was a bad sign, that you had one of the most aggressive subtypes. Now we have so many good targeted agents there that I think people are almost excited to hear that they have a HER2 positive or overexpressing breast cancer, because there are so many treatment options.
Yeah, the treatment landscape has changed dramatically, even within recent years. When the FDA has approved 3 new drugs for HER2 positive disease just in the last 2 years. So it's a rapidly evolving landscape. We're getting better and better at this, and that undoubtedly spills over in terms of improved outcomes for patients with HER2 positive breast cancer. So it's an exciting time. What we still lack, to my mind, are decent sized clinical trials that are specific to HER2 positive breast cancer, that are specific to inflammatory breast cancer patients. And, I think, one of the big issues in this field continues to be that we lack nuanced data from large populations looking at patients with inflammatory breast cancer. And what we tend to be left with is data frequently coming from single institutions, sometimes very good institutions, the Memorial Sloan Ketterings and MD Andersons and Dana-Farbers of the world that turn out very good data and evidence. But we don't have the large phase 3 trials that tell us whether or not there might be therapies that are specifically better for patients with inflammatory breast cancer. Wish we had them.
Yeah, it's sad that we miss the information coming from those community patients who, aren't captured in those large academic kinds of centers. Often those are folks who are referred there from a community center.
Mm-hmm.
And like you say, often the data that we do get to see is just from a single institution. And sometimes that probably looks better than what the general population might show.
If you're, this is the sort of expert conundrum, which is to say that, I think we all of us in medicine believe that if you're treated by someone that sees a lot of something and treats it regularly, mm-hmm. you're likely to be in better hands. I mean, that's true for just about every aspect of medicine, be it cataract surgery or open heart surgery or systemic therapy for cancer. You want to be in the hands of someone who has real expertise. The problem, of course, is that most patients don't have that advantage. Most patients are diagnosed in places where they're probably not going to be being treated by someone who has an immense amount of expertise. This is why knowledge is really important. This is why second opinions are always useful.
Right.
This is why looking around and thinking deeply about who you want to be treated with is very important if you're a patient with inflammatory breast cancer or indeed any cancer.
Absolutely. That's something that we often find ourselves talking with newly diagnosed patients about, especially if they are not living close to one of the few academic centers that has expertise. We encourage them to talk to their own treatment team about being willing to talk to someone who maybe has more experience in treating the disease.
Yeah.
They realize that doctors do talk to one another and are willing to do that.
So something I learned very early in my career is that there's no shame in asking for help. There's only shame in not asking for it if you're not knowledgeable.
Right, because it is very difficult for some patients to travel. And if we tend to be younger patients, it may be difficult for someone who has young children, financially, plus insurance. Sadly, your treatment is dependent upon your zip code.
Yeah, way too much. Way too much.
I was very fortunate. I was in a community center, but my doctors contacted the National Cancer Institute. Mm-hmm. And not all doctors are quick to do that kind of thing. And so patients really do have to advocate for themselves and speak up.
Indeed. A good friend of mine, Cliff Hudis, who's is the CEO of the American Society of Clinical Oncology, told me once that whenever he was in a room with a patient, there were two experts in the room. There was an expert on breast cancer and there was an expert on the patient. And those two experts had to agree before you got anything accomplished. I think the expert on the patient probably needs to look in the bona fides of the expert on the disease.
Yes, and it is important. I like to hear that from Dr. Hudis, because I think some doctors forget that they are treating a person first and the disease second.
Yeah. And
that is always a challenge, I think, because you're anxious to make sure the patient gets well and to keep the disease under control, but we're still a person as well.
Yeah. Well, and indeed, and of course, the patient is anxious to get their treatment underway and put it past her. Mm-hmm.
Absolutely. And that, I think, leads into the challenge of clinical trials, because if you're talking about a clinical trial that needs to be done with neoadjuvant or pre-surgical chemotherapy, you may not have that window of opportunity to get that in quickly because someone wants to move straight into treatment.
Well, and indeed, many of these cancers, triple negative breast cancers, for instance, tend to be more rapidly growing breast cancers. HER2 positive breast cancers tend to be more rapidly growing breast cancers. So there is some urgency in getting going with therapy.
Yeah, I hear that a lot from patients that they don't want to wait and are frustrated at the time it takes to move forward.
Yeah.
And in the United States in particular, we're pretty spoiled in that we can move into things quickly. You and I both are very involved in some global work and find out things are not that case in many places. And it's much more difficult for patients in other places to get that immediate treatment.
Indeed. And indeed, one of the fascinating things about inflammatory breast cancer is that there seem to be real differences around the world, not just in treatment, which shouldn't surprise you, given the differences in wealth around the world, but also even in terms of incidence of breast cancer. For instance, there's an area in the northern Africa called the Maghreb. I think it's Tunisia, Morocco, Algeria, that area where there's an exceptionally high incidence of inflammatory breast cancer. And indeed, one of the only phase 3 clinical trials that I've ever seen in inflammatory breast cancer was conducted in that area. So there are probably real differences, not just in terms of your zip code, but in terms of your country of origin.
Right. What about the topic of reconstruction? Because that comes up a lot in all breast cancer, but I think in inflammatory breast cancer, particularly because we always have a mastectomy. There is no such thing as breast conserving therapy, at least according to standard of care now. There are a few physicians who are pushing that it's safe, but my jury is still out on that one. If you have a disease that doesn't have a solid mass, it's a little hard to know if you've removed enough tissue.
Indeed, and I must say the jury is still out for me as well. Certainly one of the typical forms of reconstructive surgery that we do for many other forms of breast cancer, is an immediate reconstruction. But immediate reconstructions have their issues in patients with inflammatory disease. First, and this is just a dumb practical issue, getting a surgeon and a reconstructive surgeon, general surgeon and a reconstructive surgeon in an operating room on the same day can be a challenge in many places and can certainly lead to delays in terms of time going to surgery. So that's a simple, dumb issue, but a real one for many patients. The bigger issue, though, is the one that you mentioned. If you want to do immediate reconstruction, by definition, if you're doing immediate reconstruction, you do not have the pathology results in hand. And if a patient has residual disease that's outside the surgical margin and you do an immediate reconstruction, that certainly gives you great angst about the patient's likelihood of having a local recurrence and indeed the need for further general surgery. So certainly in my center, this is something that makes us very uncomfortable, and we generally don't recommend it as part of the surgical approach.
Well, my understanding too, that because radiation is essential as part of the trimodal treatment, if you have someone who does with implant surgery, that's not going to do real well simply because of the radiation that will follow the surgery.
Indeed. And, a great deal of reconstructive surgery today is actually involves microvascular surgery. You need good blood vessels going to the reconstructed area. And of course, radiation can affect those blood vessels. I talked about the delays in terms of getting into the operating room. Of course, reconstructive surgery can, in some cases, if you have a wound healing problem, for instance, which is certainly more common in a reconstructed breast, can delay time to going to radiation therapy as well. So, for a number of reasons, this is something that I think gives many of us a fair amount of angst in terms of suggesting to patients as a possibility.
Yeah, I think this current standard of care is 1 to 2 year wait. Some doctors, especially if it's a triple negative inflammatory breast cancer, because of the higher risk of recurrence in that subtype, suggest a little bit longer time period, more toward the 2 than 1 year. Back in my day, it was 3 years was a good idea.
Uh-huh.
And in my case, I chose at 3 years, I wasn't going to bother. I was finally feeling good, and it wasn't as important to me, but techniques have improved drastically since back then.
They have indeed. And I think pathologists, of course, are also paying great care, not just at the time of the initial surgery, but at the time of reconstruction, at the time of delayed reconstruction.
Are you familiar with anything exciting going on in the research community now with inflammatory breast cancer?
Well, this has been an area of considerable research, though not an area where I think the research has actually advanced the care of patients in a particular way. So here we get very geeky very quickly, and we get into names like caveolin and Rho GTPase, very obscure, geeky scientific names. And these are things whose presence we see more frequently and tend to be upregulated, expressed more frequently in patients with inflammatory breast cancer. And I must say that they represent interesting biology, but they haven't gotten us any closer to finding a best treatment for patients. Part of the issue, again, gets back to what we discussed earlier, which is to say that inflammatory breast cancer, like more general breast cancer, represents a family of subtypes. Some ER positive, some triple negative, some HER2 positive. And because of that, trying to come up with a general biology for inflammatory breast cancer has been difficult.
I'm well aware of that, as we've been looking at that as an organization in a collaborative effort with 2 other organizations, realizing that we just really have not narrowed down. Are there molecular markers to help identify inflammatory breast cancer?
Well, certainly your foundation, along with the other 2 that we could both name, one of which I work for when I'm not doing my day job, have invested significantly in terms of research funding in this area, and which is very exciting. But again, I don't think we're there yet in terms of either understanding the biology of why breast cancer cells invade the dermis, invade the dermal lymphatics. Nor if we had that understanding, we don't yet know whether or not it would alter how we approach treatment for patients. And ultimately, of course, the whole point of doing research is to come up with better therapies for patients.
Right.
To date, the better therapies that we've come up for inflammatory breast cancer have come out of the fact that we've come up with better therapies in general for triple negative breast cancer, HER2 positive breast cancer, and ER positive breast cancer.
I think one of the reasons we tackled this project recently is because we want to see if we can do a better job of diagnosing, simply because up to this point, because it is a clinical diagnosis, it's very subjective. And some of the guidelines people have been using in the past, or going by textbook figures that they've seen when they were in training, may not be adequate, especially for those first people who see inflammatory breast cancer or potential inflammatory breast cancer patients. Like you said, those are in the community. It may be the OBGYN, it may just be the family practice doctor, or a dermatologist. I hear more and more people end up at a dermatologist because of a rash.
Yes.
And trying to get a good history from that person so that if this is something that's happened quickly, hasn't responded to maybe a course of antibiotic, to move the person through the system faster so that they don't go through 3 or 4 antibiotics before someone finally says, gee, we maybe should do a biopsy here.
The most difficult part of the diagnosis is just simply considering it as a possibility.
Right.
Once you consider it as a possibility and you've tried a single round of antibiotics, not unreasonable, then you should move quickly to getting a diagnosis done as a result of a biopsy of the skin, and of course appropriate breast imaging.
Does one skin biopsy, is that adequate, or is it a good idea to do more than one spot?
You may well, it's probably appropriate to do more than one spot. Something that has been seen commonly when we do skin biopsies is that in one place you may get some evidence of inflammation, but actually no cancer cells being found in the biopsy. And it may well, and indeed commonly does, take more than one biopsy or more than one biopsy of one site to make the diagnosis.
That was my understanding, because the cells do tend to cluster. And so it would be pretty easy, since a skin biopsy like that is pretty small.
Yeah. And you can get very patchy uptake of the inflammatory cells. And of course, if one does breast imaging and sees a mass or microcalcifications on the imaging, of course, it's entirely appropriate not just to biopsy the skin, but also to biopsy the underlying mass.
Mm-hmm. Are there other things that come to mind for you that people ought to know about inflammatory breast cancer?
Well, I guess if I were asked to give parting words, this is a disease that, like all of breast cancer, has changed a lot over the last 20, 25 years, particularly in terms of its prognosis. And this is a serious disease. It's a dangerous disease. It's a potentially life-threatening disease, but it's not a hopeless disease. Mm-hmm. It's a disease where, patients entering this with knowledge and being treated by people who know how to treat it have the potential to have long, happy lives and be cured of their disease. And I only have to look at the screen in front of me to have a wonderful example of that. This is, I think, like all areas of breast cancer, an area where I have great hope and excitement for the future.
Yeah, I do too. When I see how much has changed in the time since I was diagnosed to what I see now, it just kind of boggles my mind. And that I do see more people living longer. Sadly, like all breast cancers, there are still patients who, no matter what we try to provide for treatment, their disease does not respond well to the treatment. And those are the frustrating, difficult ones to cope with. I know for you as well as those of us in the advocacy community. I think it's important for people to understand this is not a new disease. When I first remember reading Sir Charles Bell talking about it in like 1812 or something. Yeah. And then the Lee and Tannenbaum articles from the early 1920s, when people say, oh, well, this is a new thing, I've never heard about it. And I go, oh, no.
Well, each generation rediscovers inflammatory breast cancer. And I'm sure that those who follow me will as well. But hopefully they'll have better treatments and a better understanding of the biology.
That's our hope, isn't it? Because there's going to be, sadly, I thought when we started our organization in 1999, I think we were naively figuring this would be figured out in the next, 8 to 10 years. Well, that was 22 years ago.
So I will say to our listeners, for those of you who have inflammatory breast cancer and those of you who are interested in this, you couldn't go wrong providing some support to the Inflammatory Breast Cancer Foundation. Ginny's organization has been a leader in this field, both in terms of disseminating knowledge, but also in terms of focusing and supporting our research efforts, for which you, my dear, deserve an immense amount of credit.
Well, thank you very much. Well, thank you so much for your parting words and for your encouragement. I keep hoping there's going to be someone come along to replace me as I look toward retirement at some point in my life.
You and me both.
Well, thank you so much for sharing. I appreciate it. And I'm sure people learned a lot.
Thank you ever so much for inviting me.
Thank you.